One of the more popular questions I get is, when should I start getting checked for prostate cancer? While we just recently wrapped up Prostate Cancer Awareness Month, here on the Prostate Health Podcast, we continue to educate and empower men and those who care for them year-round. How we screen for prostate cancer continues to evolve, and today we'll work on answering all of your burning questions and how you can be smarter about prostate cancer detection. So stick around. So the big question is this: how can men and those who care for them better educate themselves regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions? That is the question, and this podcast will provide the answers. On a weekly basis, we will be chatting with experts, innovators, and leaders in the field of urology, sharing useful information with the general public to improve their lives and increase their overall health. My name is Dr. Garrett Pohlman, and welcome to the Prostate Health Podcast. Prostate Health Podcast is for informational purposes only. Nothing in this podcast should be construed as medical advice. By listening to the podcast, no physician-patient relationship has been formed. For more information and counseling, you must contact your personal physician or urologist with questions about your unique situation. I am thrilled to have joining us today prostate cancer expert Matt Cooperberg from the University of California, San Francisco. His bio is certainly long and impressive, and I had a difficult time condensing it for his introduction here today. He has earned his MD and MPH degrees at Yale University and completed residency in urology and fellowship in urologic oncology at UCSF. At the end of his training, Dr. Cooperberg joined the faculty at UCSF, where he maintains busy clinical practices at the UCSF Hellen Diller Family Comprehensive Cancer Center and the San Francisco VA Medical Center. He has written in or contributed to over 350 research articles. Through his clinical and research efforts, he continues to lead the way for a paradigm shift for smarter prostate cancer screening, with rational and risk-stratified prostate cancer screening, as well as appropriate risk-stratified treatment strategies. Dr. Cooperberg, welcome to the Prostate Health Podcast.
Thanks for having me. Pleasure to be here.
So Dr. Cooperberg, you also hold a secondary appointment in the Department of Epidemiology and Biostatistics. I thought you would be an excellent candidate to just briefly review for our listeners today, how common is prostate cancer?
Sure. So prostate cancer is extremely common. And I would say at the outset, by the way, that the way I wound up getting the secondary appointment, I had a public health degree during med school, MD and MPH, which was fantastic additional training, gave me a background in statistics and a view on the healthcare system from the 30,000-foot viewpoint, which has always been a fantastic complement to the one-on-one patient interactions that I have in daily practice. And the two have informed each other throughout my career. But when I was junior faculty at UCSF, I got involved in a number of friendly debates with various folks in primary care and epidemiology at UCSF for the medical students. And, I've always been very data-driven in my approach. And ultimately, they offered me a secondary appointment as kind of in reflection of the work that I've done with primary care at UC. And it's been a really terrific part of my career as it's evolved. So to get back to the question, prostate cancer is extremely common. If you live long enough, almost every man is going to get some cancer cells in the prostate. And in fact, when they do autopsies of men who die of other causes, something like 30% of men in their 30s have a couple of cancer cells identifiable. And by the time you get to your 80s, it's almost everybody. And this highlights the fundamental challenge, which is that we use the word cancer for a lot of things in life, ranging from completely indolent and unimportant to very aggressive. And prostate cancer tends to be at the low end of that spectrum in terms of its aggressiveness. And then within prostate cancers, there is huge range from completely indolent and unimportant to quite aggressive. So at the histologic level, meaning in terms of cells we can see under the microscope, like I said, it's almost everybody if you live long enough. And of course, most of those are totally unimportant. You live your entire life not knowing you had it, and that's absolutely fine. Roughly 1 in 6 men in America are ultimately diagnosed with prostate cancer throughout the course of their lives. And eventually, about 3% of all men in America die of prostate cancer, somewhere between 2 and 3%. So it's by far the most common cause of cancer mortality among men following lung cancer, but it's a much, much, much smaller number, the number of those diagnosed with prostate cancer.
So can you share with our listeners then, how is prostate cancer detected?
Yeah, so the vast majority in this day and age are found with screening or early detection using a blood test called PSA, which is prostate-specific antigen. The old way of finding prostate cancer before PSA came to the market in the 90s was basically waiting until it had clinical symptoms, meaning until it was causing blockage of the urinary stream to the point that men could not pee, or it can grow into the bladder and cause bleeding, or eventually gets into the bones and causes pain and other problems there. And the problem is if you wait until you know you have it and it's causing symptoms, it's far too late to cure it. So these days, the vast majority of prostate cancers are found with PSA testing, using this blood test.
So how has prostate cancer screening really evolved over the years then?
Yeah, so when PSA was being developed in the early 1990s, late 80s, it was tested for the most part in men who were in urologic practice. And for the most part, it was men in their late 60s, mid to late 60s. And that actually set off the problem and the controversy that we've been dealing with for the next 25 years. Because like I said a minute ago, PSA is prostate-specific antigen. It is not prostate cancer-specific antigen. And anything that happens to the prostate as a man gets older can cause the PSA to be elevated. And the most common alternative explanations, aside from prostate cancer, are BPH, which is just benign growth of the prostate gland, which is also extremely common as men get older, and prostatitis, which is infection or inflammation of the prostate. And the problem is the older you are at the time of the PSA test, the more likely it is that you're going to have other explanations for an elevated PSA. And basically there's more mud in the water. When PSA is used for young men, it's actually an extremely good test because the PSA below the population median, which is around 1 for most men up to age 60, you can basically write off prostate cancer as a concern for the next 20 to 30 years. That's not the way PSA was used. So the most common age for many, many years, year after year after year, there have been studies over the decades that the most common age at which an American man gets a PSA test is in his late 60s or early 70s. And that's where there's all this mud in the water from BPH and other things that have happened to the prostate over the years. So a lot of men show up with an elevated PSA because of reasons that have nothing to do with prostate cancer. And historically, a lot of them would go down the path of getting a biopsy, which is the only way to diagnose prostate cancer, but does have its own risks and is uncomfortable. Many of those biopsies would be negative, so they were unnecessary procedures. We would find too many low-grade prostate cancers, the kind that I mentioned earlier, don't really matter and never cause a threat to symptoms or length of life. And we were too late in finding a lot of the aggressive ones, the ones that are ultimately going to be lethal. A man who dies of prostate cancer in his 70s or 80s had that cancer in his 40s, 50s, or at best 60s. And that was when we needed to find them in order to cure them and prevent this slow, painful death from prostate cancer much later in life. The evolution that we're trying to engineer now is the result of a pendulum swinging back and forth over the decades. So when PSA first hit the market, everybody and his uncle ran out and got a PSA test with his primary care doctor. There was this huge wave of detection of these, the term is latent prostate cancers, meaning men that had just been living out their lives happily oblivious, not knowing that they had these prostate cancers. And then we found a huge wave of them in the 1990s, some of which we had to find, many of which we did not. And there was a corresponding wave of overtreatment. So there was a lot of surgery and radiation and other treatments done in the 90s and 2000s for these low-risk tumors that never needed any treatment. And it was the early days of radical therapy, so the side effects were pretty common. Quality of care was not what it is today. So many, but let's be clear. Let me back up for a second. PSA screening has saved many thousands of lives in the United States and elsewhere in the world. But the price of that through the 90s was many more thousands of men who underwent avoidable surgery and radiation therapy and other treatments they did not need. And a substantial proportion of those men suffered long-term consequences like erection problems, urinary problems, bowel problems, things that they should not have had to go through because we didn't implement PSA testing well. We screened too late, we screened too frequently, we focused the attention of treatment on low-risk disease, and we undertreated high-risk disease. So the upshot from all that was that the primary care community, who are the ones actually doing PSA screening, it's usually not up to a urologist, it's usually a primary care doctor that decides whether or not to raise the issue of testing with the men. Primary care doctors basically threw up their hands and said, we're not having any more of this. And there's a body called the U.S. Preventive Services Task Force, which recommended in 2012 that no man should get PSA testing ever. And that really did throw a real ice water bucket over PSA testing in the U.S. Incidence rates fell 25% across the board. And we started to see a decline in overdiagnosis of low-risk disease, but also an increase in the likelihood of aggressive disease and in metastatic disease at diagnosis. And basically the feeling is this is the baby out with the bathwater, that yes, this was one way of addressing the overdiagnosis, overtreatment problem, but it's sending us back to the 1980s paradigm of don't do anything until it's too late. And of course, men are living a lot longer. They're less likely to die young of cardiac disease. So the implications of sending us back to the 80s are much, much worse this time around than they would have been back then. So now we're trying to swing the pendulum back to a middle ground of a smarter approach to screening, which should have the benefits of early detection while minimizing the harms.
Well, you've certainly been a leader in the field of urology in shifting this paradigm toward, again, smarter prostate cancer screening. But first of all, for our listeners, again, what is smart prostate cancer screening?
Yeah, so that term, we use that term and others use that term. There's lots of different sort of pillars of it, or planks, if you will. But the key principles that we've been trying to push from UCSF and elsewhere over the last few years are, number one, PSA really should be used as an early baseline test before there is all this mud in the water. So when a man is in his 40s or early 50s, most men do not have BPH. There are fewer years during which episodes of inflammation and prostatitis may have built up. And basically PSA is a much cleaner test when men are at younger ages. Now, there's a critical point there, though, which is that you have to forget all about 4.0 as the threshold. So when PSA was introduced, people used 4 as the cut point. Under 4 was considered okay. Above 4 is considered, potentially at risk. And it really doesn't work that way. It's much more dependent on patient's age, prior experiences, BPH, et cetera. So in a man's late 40s or early 50s, the median, so the middle of the population, is around 0.8. By the time you get to 60, it's around 1.0. But that means, again, that well over half the population can do a single PSA test and be very reassured that they are done, that they do not have to worry about prostate cancer, potentially for life, certainly for the next 20 years plus, based on some very good studies that have been published over the last few years. Now, if the PSA is relatively high at a young age, that's a big red flag. And when I say high, even 1.5 or 2 for a man at age 45 or 50 is a potential problem. So the thinking is get an early baseline test. What defines early is a little bit controversial. Many of us argue for around 45 or 50, and even earlier for men who have risk factors, such as African-American men, those with a family history, or those with any sort of genetic red flags like BRCA mutations in the family. They should consider starting even at age 40 to get a baseline test. Because again, the ones that are eventually lethal, some men die in their 50s and 60s. Those men had cancer in their 30s and 40s. So men with risk factors should consider an even earlier baseline. So it's getting an early baseline test. But then for the majority of men who have a low baseline number, don't check it every year. Don't check it every 2 years. You don't need to check it again for many, many years. We are trying to operationalize every 5 years, but it could be even longer. Then for men who have an elevated test, which at UCSF we are calling over 2 for men under 60 or over 3 for men over 60, we go down a path of workup. So not necessarily rushing to biopsy, but doing secondary tests. There's a number of biomarkers, there's MRI, there's a few things that we're using to try to tailor the decisions about biopsy or not. And then for men in between, well, it's a gray zone. And we tailor those discussions together with the man. So between 1 and 2 for a man up to 60, and between 1 and 3 for men over 60, we have a conversation about whether or not to go forward with testing. And there again, we're influenced by race, by family history, by men's overall health, risk aversion, et cetera, and preferences. And all those are totally reasonable considerations. When we find prostate cancer, we don't treat low-risk disease. And it's really important that the man understands that before the biopsy and ideally before the PSA test. The purposes of a PSA test is to find potentially lethal prostate cancer. Along the way, we may find the indolent, we call them Gleason grade group 1, Gleason score 3+3. There's lots of different names for this. A lot of us are starting to think we shouldn't call this cancer in the first place because it cannot metastasize. So the man needs to understand that just because we use that C word does not mean he needs to rush into treatment. And that's a critical part of smarter screening, is that the treatment likewise be done smarter.
Well, excellent overview. And now, so what are some of the benefits, that you're seeing so far with the smarter prostate cancer screening?
Yeah, the goal is to get the best of all worlds. The goal is to realize the survival benefits that are unquestionably attributable to early detection while minimizing the harms, avoidable surgery and radiation and other things that did not need to be done. There's lots of modeling studies trying to figure out just how many lives saved relative to how many side effects spared and all that. It's a little soon to try to put numbers on anything that we can say we have actually driven in the community, but I will say for sure what we are driving is a much more productive conversation with primary care than we have had for years. Because like I said, throughout a lot of the last decade, the stance from the primary care doctors was the urologists are just in it for the procedures and the money and really don't care about the patients, and they've been driving all this unnecessary treatment for all these years. We're done. And really wouldn't even have a conversation about what the right path is. So we are now having that conversation at UCSF and a lot of other centers, in large part because urology is driving this understanding that we need to be doing this all better. We don't want to go back to the 90s or 2000s, but we also don't want to go back to the 1970s and 80s. We need to find this common ground in the middle. And I think that's the message that is finding some resonance with primary care leadership. And even the U.S. Preventive Services Task Force in 2018 now has a recommendation for shared decision-making, meaning there should be a conversation between the men and the primary care doctors. Still a pretty flawed document, but it's a lot better than the 2012 version was.
You kind of hinted to this a little bit and kind of mentioned some of those tests in terms of what you use at UCSF. But in terms of utilizing tests that can maybe be helpful in supplementing the PSA and the prostate exam as we counsel men on their options, have you kind of found a few go-to tests that you'd like to utilize in kind of giving more information there and maybe making that decision on whether or not to do a biopsy?
Yeah, there's a growing array of options here. So the old paradigm was elevated PSA, you get a biopsy. Now there are a number of tests which can live in that space between the elevated PSA and the biopsy. And it depends on the details. If the PSA is 20, that guy, or if there's a big nodule on the rectal exam, that gentleman needs a biopsy almost no matter what. But for many men, for most men who undergo a PSA test, it's some shade of gray. And these biomarkers can help us figure out whether it's a darker or lighter shade and whether they should go forward with biopsy. So these are blood tests and urine tests. The blood tests are looking at subsets, what's called isoforms of PSA. There's one called the PHI, Prostate Health Index. The other is called the 4K test. Then there's also urine tests. There's one called SelectMDx, another one called ExoDx. And we've used all of them to varying extent. Between the two blood tests, we tend to prefer the 4K at UCSF because it actually integrates the other information like the age, race, family history, et cetera, to give us a % likelihood of high-grade cancer. So the way the test is formatted is a little bit more actionable, in my view, than the PHI, although the science is probably very similar. We've also used both the SelectMDx and ExoDx tests quite a bit. Those are the urine tests. And both of those give you, they're formatted very well in that they give you a high, what's called a negative predictive value, meaning if you get one of these tests, the goal is to rule men out for biopsy. So if the test is negative, you can be pretty sure they're calibrated to like 95 to 98% certainty that there is not a high-grade cancer there. There might be low-grade cancer, which again, you don't need to know about, but you can be sure, reasonably sure that there's no high-grade cancer. If the test is positive, maybe there is, maybe there isn't. We usually say, well, it's worth going down the path of a biopsy at that point. These days, we're using the ExoDx test even a little bit more because they actually have an at-home urine test. So it's keeping the patients out of the clinic during the COVID era, which is a good thing.
Great. Now, again, we chatted about this a little bit earlier on, but again, with multiple different guidelines out there for prostate cancer screening, I believe there's definitely still a bit of confusion, especially for primary care providers in terms of who needs screening for prostate cancer and when to do it. And some controversy here as far as when to start, but of course I might be putting you on the spot here, but at what age do you typically recommend men start undergoing initial prostate cancer screening?
Yeah, like I said, I think there's a pretty strong argument for somewhere between 45 and 50 as the initial baseline test. Again, understanding that the threshold for normal at that point should be under 1, and that when you get a test under 1, you don't get another screen for many years. And that if we find cancer, even in a 45 or 50-year-old, if it's a low-grade cancer, that man does not need immediate treatment. And those are really critical caveats to that recommendation. The earlier age as an early baseline, I think is very, very well supported by a number of good studies, not by prospective trials, but by some excellent research that's been done from cohorts over a number of years. The age at start controversy really reflects the different methodologies that the different guidelines have. So the U.S. Task Force now recommends a conversation between age 55 and 70. And the American Urologic Association likewise focuses on this age 55 to 70. That's not because there is a shred of evidence that that's the optimal time to screen. It's because there's only one really useful multi-center randomized controlled trial of screening versus no screening. It was a European trial called the ERSPC, and that was the core age in that trial. So those two guidelines, the U.S. Task Force and the AUA, decided they would only use randomized trial evidence, so their guideline focuses on the 55 to 70. But there are some other really well-done studies suggesting that the benefits are even greater at a younger age using a lower threshold. And I do believe those studies should be given credence. So if you look at the American Cancer Society and the NCCN, they all recommend earlier start ages. And again, I do think that start age should be tailored based on race and family history.
So kind of following that question up, then how long do we need to keep screening men for prostate cancer as they get older on the other end?
Great question on the other end. And everybody always talks about the stop age. Yet what you have to understand about that is there's a big difference between stopping in a man who has been screened and saying you should never get a test in the first place. So, there's a fair consensus around 70 or 75. Life expectancy does continue to drift up. So, between 70 and 75 is a reasonable stop age. But there's a huge difference between a man who's had 4 PSAs between 50 and 70, and they're all 0.8, and a guy who's 70 and has never had a PSA test before. So, somebody who's 70 or even in his late 70s and is in really good health and has a great life expectancy and a great quality of life and has never had a PSA test, I would say it's worth the conversation. Not saying he needs to be screened, but it's worth the conversation. The problem is that's not what happens in primary care. A lot of docs either screen everybody or they screen nobody. And this has been shown in a couple of great studies. There was a nice VA study. The veterans population tend to have a lot of other health concerns. Life expectancy tends to be a little bit less. And there was a great study from Louise Walter years ago looking at screening practices in the VA. And they found that something like 60% of men in their 70s in the VA system were getting PSA tested. But the sicker men with more other health conditions, were a little less likely to be screened. Men 85 and older in the VA, still about 1 in 3 were getting PSA tested. And it's not because anybody was having some discussion with them about risks and benefits. The primary care doc was just sort of checking the box along with 50 other blood tests every year. That's not the right way to do it. And even those of us who are huge advocates for screening would say the only 85-year-old who should get a PSA test is the one who brings both of his parents to the primary care visit with him. And that's obviously not what's happening in the VA system. So, these decisions really do need to be tailored and customized. I don't think there is an automatic stop age. I think, most men in their 70s don't need testing if they've had reassuring testing before. Now, the other important point there is a man who's at a marginal PSA or a PSA of 3 or 4 in his 60s, testing him in his 70s, not screening anymore, that's surveillance and is totally appropriate. So a man who has had, like I said, reassuring PSA levels earlier in life can stop. And reassuring is, again, under 1, can probably stop by 70 or sooner. But a man who's never been tested could consider it. And a man who's had an elevated PSA, that's not screening, it is surveillance.
So wrapping up the show today, I wanted to hit on one more topic. So now for those men initially diagnosed with prostate cancer, again, I think for a lot of them, the initial knee-jerk reaction is for them to want to rush into radical treatment right away, whether that's radical surgery or radiation therapy. Now, there certainly is a growing consensus supporting active surveillance as a preferred strategy for certain candidates. Which patients do you feel are good candidates for active surveillance?
Yeah, I think you really said it exactly right in that it is finally a growing consensus. Academic centers like UCSF, Johns Hopkins, Toronto have been advocating for surveillance for many, many years, but there's been this perception that it's an academic endeavor, and it really did not have much traction in real-world community practice in the U.S. until the last decade. And frankly, there is some acknowledgement that the U.S. Task Force recommendation, to stop screening altogether, in part did help light a fire, I think, under the urology community, that if we don't retake the terms of the conversation, we are going to be cut out of the conversation in terms of how screening should be done. So, in part because we saw the pendulum swing so far in the wrong direction, I think has been one of the drivers of greater community acceptance of surveillance, and also just the maturation of the academic series and increasing understanding that it is safe. So in 2020, it's a pretty safe statement that almost everybody with low-risk disease, meaning a PSA under 10, a Gleason score 6 or a grade group 1 tumor, and a clinical stage T1 or T2 are good candidates for active surveillance. There are ways to substratify the low-risk group. I don't think the very low-risk category is necessary to define candidacy for active surveillance. Most men who tick those 3 boxes can certainly consider surveillance as a preferred first initial strategy for managing the prostate cancer. And the understanding, again, is that this is a cancer that grows and progresses over years and decades. And the window of opportunity for cure is likewise measurable in years and decades. So active surveillance does not mean go home and forget about it. This never needs treatment. It means we're going to follow this carefully. And if we see signs of the cancer growing, then we will treat with every intention and expectation of cure. And it's frankly become a much easier conversation over the years. It used to be we would spend 45 minutes sort of talking to the guy back from the cliff about, he's heading for radiation or surgery for this tiny little 1 millimeter microspeck of low-grade prostate cancer that, 7 prior urologists and radiation oncologists have been all lined up to treat. I think these days surveillance is much more out there in the vernacular, both in patient support groups and in community urology practice. So we really did see a sea change in the first half of the last decade, and we're now up to about half of all men with low-risk disease who go on surveillance. Now, I'd say that's still too low. The optimal number is probably around 80%, not 100, but it should be around 80%. There will always be some men who have good rationale for immediate treatment. Either they've got a terrible family history or they've got really severe obstructive symptoms, so we're killing two birds with one stone by intervening. Or, there's other scenarios like that, but they're uncommon. And 80% is probably a reasonable target number for the proportion of low-grade men who should be on surveillance, at least initially.
Now, are you finding any of the available supplemental studies useful in helping tailor kind of the decision-making for these men who might be candidates for active surveillance?
Yeah, absolutely. So in that space, we have tissue tests. So there's the Decipher, Oncotype, and Prolaris, as well as MR to an extent, which can help tailor these decisions. I tend to think of them as tiebreakers. I don't think there's any group of men who absolutely need one of these tests before making a decision. I tend to use them personally for borderline candidates, meaning they have Gleason grade group 1, Gleason 6, but it's very high volume tumor, or we have been pushing the envelope in terms of putting more and more men with Gleason 3+4 or grade group 2 tumors on surveillance, or for men who are really anxious, who are particularly young, strong family history, anything that is driving any kind of uncertainty is still the right thing to do. The markers can be very good as tiebreakers in those scenarios.
And finally, what is your kind of preferred active surveillance protocol currently?
Yeah, it's evolving very quickly. So the UCSF protocol for many years was a biopsy it was a PSA every 3 months and a biopsy every 1 to 2 years. And we would intersperse extra ultrasounds and physical exams in between. These days, we are really tailoring the surveillance protocol more and more, recognizing that, we would always quote men about a 50% chance of needing treatment within the first 5 years on active surveillance. But the reality is, out of every 100 guys that go down the surveillance path, yes, about half will eventually be treated, but most of those we're treating just because they're reclassified. There was always a little bit of higher grade cancer there. We just happened to find it on the subsequent biopsy, but the cancer didn't really get worse, and they haven't lost any ground during the period of surveillance. There's a small number, and these are rare enough I can remember their names and faces, where the biopsy progressed so much over 6 months or a year that by the time we finally get them to treatment, well, now there was extra prostatic disease and the cancer comes back after surgery or radiation, and we're really sort of kicking ourselves, wishing we'd done something a year prior. That is extremely uncommon, no more than a couple percent. And that's balanced by a huge pool of men who, we do a second biopsy, we don't even find the cancer the next time. The PSA goes down, not just low risk, but, these tumors that really should not bear the term cancer, and those are really quite common. So we're really trying to turn down the intensity of surveillance for the large number of men in that group. So we actually just had a study out in JAMA Oncology looking at outcomes across 9 big centers across the United States, basically finding that we can tailor the intensity of surveillance with good confidence. So for men who have very reassuring risk parameters, so things like I just mentioned, PSA is flat or going down. We've seen negative biopsies. The PSA is relatively low for the size of the prostate, things like this. We can avoid doing biopsies and MRIs and things like that for at least up to 4 years without any appreciable risk of the cancer getting substantially worse. So that's the future. I think it's, surveilling pretty intensively for men who we're actually worried about, but minimizing the intensity of surveillance for the pretty large group of men who frankly have minimal biologic potential for the cancer to actually get out of the prostate where it will cause problems.
Well, certainly some great points there. And I would just really appreciate your time today, certainly to be commended on your continued work on smarter prostate cancer screening and treatment, which should definitely allow for further reduction in prostate cancer mortality, but minimizing overdiagnosis and overtreatment. Dr. Cooperberg, any final thoughts for our listeners today?
No, I think be informed. And, I would say that these decisions are still made in primary care offices, not in urology offices. And the knowledge and stance about testing across primary care providers is still, as you'd expect, all over the map. There are some primary care docs who are very attentive to these issues, are very keyed in about smarter screening and really know the literature. There's others who are still in the 2012, I don't test anybody ever sort of framework. And there's some who still screen every man every year until he's 87. So, don't be afraid to ask pointed questions. It's very reasonable to ask for a test, even if the primary care doc is not raising the issue him or herself or is resistant to it. Just make sure you're well informed. And again, understand that the purpose of testing is not to find prostate cancer, it's to find the subset of the prostate cancers that actually may cause problems.
Well, again, on behalf of all of my listeners, I just want to thank you for coming on and really providing exceptional wisdom that I know anybody that listens to this is going to find super value from. So thank you again.
It's a pleasure. Thanks for the time.
Thank you again for listening to the Prostate Health Podcast. We would love to have you join our podcast Facebook group at www.facebook.com/groups/Prostate Health Podcast, or just use the Facebook group search function and search for the Prostate Health Podcast and ask to join. We'll see you at the next episode.